Okay, my topic today is who should be referred for atherosclerosis imaging. This is an important topic. See this, all these big celebrities, they were young, they were physically fit, but all of them died suddenly, either singing or in the gym. The message is very clear. Physical fit does not mean that your heart is fit. So, not only a diagnosis, but the time of diagnosis and the patient's identification for diagnosis is very important. It plays a very important role. Early diagnosis and treatment can stop atherosclerosis from worsening and prevent a heart attack, stroke, and another medical emergency. The sad part is that 70% of the patients, they develop MI in the low risk group. Only 12 to 18% of patients are in the intermediate or moderate risk group. And 75% patients, they don't qualify for polypharmacy. The other part is that about 68% of patients, they develop MI in the lesion which is less than 50%. Only 18% of patients or 13% of patients will have stenosis more than 70%. Means most of MI occur in the insignificant lesion. The lesions have thin cap, more atheroma, and if it progress to ACS. If aggressive therapy is given, then they may stabilize. So, friends, the atherosclerosis process starts from childhood and most of the time it remains asymptomatic. When these patients have multiple risk factors like family history, hypertension, diabetes, dyslipidemia, smoking, it aggravates the condition and then patient may present with acute MI or ACS. There are other non-traditional risk factors like HSCRP, anti-plaque index, family history, Southeast ethnicity, lipoprotein A, and other parameters which are responsible for most of the cases of MI. Now, as there is a lot of burden of coronary disease and primary prevention is very important. And for primary prevention, what you need is risk stratification. Which patient needs early treatment, which patient does not require aggressive management. And many parameters, many risk scores have been validated. Framlingham we have been using since long. It takes into account sex, age, total cholesterol, HDL, systolic blood pressure, smoking, hypertension. It gives risk of 10-year risk of developing coronary artery disease. ASCVD risk stratification by ACC takes into account age, diabetes, sex, smoking, cholesterol, HDL, systolic blood pressure, and treatment of hypertension risk. It also gives 10-year risk of in the primary prevention. Then there is Euro score, which takes into account both primary and secondary prevention. But in our Indian scenario, our patients have different risk factors and they have different ethnicity. So this may not hold true, and therefore Lipid Association of India, they have proposed very practical guidelines for Indian patients. They have grouped into low risk, moderate risk, high risk, very high risk, and extreme high risk groups. And they have put risk factors, other risk factors. These are the things which are taken into account. Now, ACC has validated that how it should do primary prevention, and therefore they have given, apart from adherence to lifestyle, they have divided these patients into low risk, that is the risk is less than 5%, 5 to 7% borderline risk, 7.5 to 8%, 20% intermediate, and more than 20 high risk. High risk patient does not require any further validation, they can stay put on treatment. The problem comes of intermediate risk group, that is between 5 to 20%. Here the ACC have put ASCVD risk enhancers like family history of premature ASCVD, persistently elevated LDL, metabolic syndrome, inflammatory conditions, rheumatoid arthritis, and in females early menopause and preeclampsias. They have to take into account. Then triglyceride level persistently high, lipoprotein A, HSCRP, these are these enhancers. Now, if the patients, you are confused between borderline and intermediate, they have rated that coronary artery calcification should be estimated. If the CAC is less than 0%, then there is no need. 0 to 99, you have to take into consideration patient history, other parameters. If the CSC is more than 100, then this patient needs statin therapy. Mind you, in spite of so much risk stratification, there are some surprises. Look at these people. Churchill, he was the obese, heavy smoker, stressful life, and died at 91. These two physically fit people, Jim Fix and Jim Russert. One was marathon runner, another was author of these news anchor. They died early in spite of being totally fit. So these parameters may not hold true. All these risk factor assessment may not hold true. You need to have something more. Imaging is very important. And therefore, you need to have thorough assessment of the patient for early assessment of the risk factors. And what are the parameters? What we do? In our clinical practice, we assess coronary artery calcification, we assess intima media thickness, we do CT coronary angiography, in some cases MR angiography, and in a high risk patient, we do IVUS or OCTs. Now, in clinical practice, these two things are very important. One is intima media thickness and coronary artery calcification. Coronary artery calcification occurs much earlier. It does not require much radiation. It can be done without artifacts and very precisely quantify the coronary artery calcification and risk profile. However, it has some limitations. It is not reproducible. It gets deposited in some particular place. And nowadays, with high dose of statins, you may have more calcification. So this may not be validated. And even if the calcium score is 0, soft plaques may be missed. And therefore, it is not that if you have 0 calcification, you have no coronary artery disease. Intima media thickness. Now, the scoring system has been made. Calcium score is 0, you have low risk. As the calcium score increases from 0 to 300, you have more risk of events, MACE events. And if this calcification more than 1000, you have 37% risk of having MACE. So this is a very important validated parameter which CSI endorsed for risk stratification in intermediate and borderline group. How about younger patients? The JCC 2022 mentioned these 4 indications. Those with suspected diagnosis of FH, those with family history of premature SCVD, those with multiple risk factors, and those with age of 40 to 45 years who are in borderline group. In these patients, coronary calcification should be done. The thing is intima media thickness. The intima media thickness can be done, should be taken as a first indication of coronary atherosclerosis. It can be done very easily. Just put a probe or carotid arteries and you can know the intima media thickness. Mind you, it gives the indication of risk factors, does not give indication of atherosclerosis because this is medial. So what they have mentioned is that you should look at carotid plaques. Plaques are very important. And then ASC guidelines, they have given very clear indication that intima media thickness is one indicator and plaque assessment should be done in all patients. And then they have given this flow chart that carotid plaque quantification and intima media thickness. You can say that no plaque is 0 risk, plaque height less than 1.5 grade 1, plaque height more than 1.5 grade 2, and plaque height more than 2.5 is grade 3. And depending on that, they may be low risk, medium risk, and high risk. These are the plaques may be diffuse, may be eccentric. This is a very good paper which recently published that meta-analysis of 1 lakh patients. And what they found that if you aggressively treating patients, if you regress intima media thickness by 10 micrometer, the cardiovascular events may decrease by 0.9. So you can have a very prognostic implication of intima media thickness. Of course, if you do MRI, you can have indication idea of lipid core, you can indication of calcium in the plaque, but it is expensive. Nobody does routinely. So these are different societies who have given 2A or 2B indication for calcium scoring and intima media thickness. We always look for carotid. We don't look at femorals. This is very good paper which look at carotid plaques, coronary calcification, and femoral plaques. What they found that femoral plaques showed better indication of coronary disease than carotid plaques. So if you do carotid femoral intima media thickness, femoral plaques gives better indication. Other important is Anchor Bacterial Index. It is a simple test, but nobody does nowadays. Anchor predictor index with Framingham score gives good indication that patient has got atherosclerosis. So this should be advisable. This should be done in our practice. Those patients who are high risk, if they go to cath lab, if you go chorangiography, you will give luminar narrowing, but will not show the plaque. For plaque assessment, you have IVUS and OCT that gives definite indication of lipid burden, other things. Now recently FFR-CT has been elaborated in the CAT assessment. It gives specific enhanced indication. It gives very good information on atherosclerotic process. It gives negative FFR is associated with excellent long-term prognosis and plaque formation can be assessed. This recent paper attached just 3 days back, so I just thought I would put it. It gives the drug effect. When the patient has CT angiography, MRI, and when the after treatment, there was change of plaque morphology. The two things is lipoprotein A. Lipoprotein is another indicator marker of atherosclerosis. If you ESC has mentioned that at least once in lifetime you should assess lipoprotein, and if it is more than 30, probably you are dealing with high risk patients. Another is HSCRP. Most of the guidelines elaborated HSCRP as one of the indication for atherosclerosis. These are the different class of indications which ESC has mentioned. Class of indication for score system, then carotid enzymatic thickness, for plaques. So to conclude, risk stratification and treatment strategies can be refined by enhanced thorough integration of biomedical, bioimaging and biochemical markers to characterize subclinical atherosclerosis. The approach should be very aggressive assessment of risk factors, look at enzymatic thickness, plaque morphology, and start treatment aggressively. Thank you very much.